Equipment. You will need the following equipment to perform the procedure: reflex hammer, flashlight, cotton-tipped swab, tongue depressor, investigation of coma.
The first thing we'll do is examine the patient and see that in point of fact, as we look up here, his heart rate is 110. His blood pressure is 89 to 85 over the 50s, and his oxygenation is at 100% by pulse oximeter. Thus, all of the metabolic conditions, and his temperature has also been demonstrated to be above 36 degrees, would be present so that we can proceed with this examination. And you'll have to take our word for it that we've interrogated the chart and made certain that there is no explanatory findings of sedating medications, neuromuscular blocking agents, or things of that nature. The first thing we would do is to see if we can discern any response from the patient at all. We'd say, hello, 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 young man. In the absence of that, we'd then see if more vigorous stimulation would provoke any kind of response from him at all. In the presence of decorticate or decerebrate posturing, we know then that parts of the nervous system are still intact, and therefore the diagnosis of brain death can't be made. It's important to remember, however, that there are certain automatic responses that don't constitute anything from the brain itself. For example, a so-called triple flexion response, flexion at hip, knee, and ankle, is an involuntary spinal response and doesn't constitute any kind of a meaningful response from the brain itself. And so in this instance, the first thing we would do is a moderately painful stimulus, for example, here at the toes. Any of a number of things can be used to generate a painful stimulus. You can put your reflex hammer in between the toes, holding onto them and twisting like this. We then look to see if there's any autonomic response, and we see that while I'm doing this, his heart rate is completely invariant and making no change at all. Finally, we'd lift back his eyelids, and we'd look to see if there's any pupillary response to this at all. Again, an autonomic nervous system change that might suggest intactness of.
Investigation of brainstem reflexes.
Next, we would interrogate the brainstem, and the first thing we would do is to see if there's any pupillary response. So the pupils at this point are mid-position, fixed, and dilated, with no response to light.
Pupillary reflex. With a normal and intact pupillary reflex, you will observe that the patient's pupils are mid-position and constrict in response to bright light. An abnormal pupillary reflex will be demonstrated by pupils that are mid-position, often dilated, and do not constrict in response to bright light. Corneal reflex, you will observe that the eye will blink when you touch a cotton swab to the cornea. An abnormal corneal reflex will be demonstrated by an absence of blink when a cotton swab is applied to the cornea.
After this, we would do oculocephalic.
With a normal and intact oculocephalic reflex, you will observe that when you turn the patient's head quickly to one side, the eyes will move to remain fixated on one position in space. In patients with an abnormal oculocephalic reflex, you will observe that when you turn the patient's head quickly to one side, the eyes will remain mid-position. It should be noted that this reflex can be difficult to assess when there is significant orbital edema, impairing the ability of the examiner to open the eyes, or with significant conjunctival edema, impairing the ability of the eyes to move appropriately.
We would next try
vestibular reflex. With a normal and intact oculovestibular reflex, when you instill cold water into the otic canal, you will observe that the eyes turn quickly away from the cold water stimulus, and then turn slowly toward the cold water stimulus in a repetitive manner. Therefore, if you instill cold water into the right ear, the fast phase of eye movement will be toward the left side, and the slow phase of movement will be toward the right side. This is a normal physiologic response known as nystagmus. After instilling cold water into the ear, you may need to wait 90 to 120 seconds to observe for any response. For patients in which there is a lack of cortical response based on earlier tests, the brainstem may still be intact. When you instill cold water into the otic canal, if the brainstem is still intact, you will observe the eyes turn slowly toward the cold water stimulus. Therefore, if you instill cold water into the right ear, the eyes will turn slowly toward the right side. After instilling cold water into the ear, you may need to wait 90 to 120 seconds to observe for any response. If the brainstem of the patient is not intact, when you instill cold water into the otic canal, you will observe that the eyes will not turn toward the cold water stimulus. Therefore, if you instill cold water into the right ear, the eyes will stay mid-position. After instilling cold water into the ear, you may need to wait 90 to 120 seconds to observe for any response before concluding that there is no response. Remember that cerumen in the otic canal will prevent the cold water from reaching the tympanic membrane, and thus you will not be able to assess this reflex. Pharyngeal reflex. With a normal and intact pharyngeal reflex, when you insert a tongue blade deep into the back of the patient's throat, you will see that the palate will elevate. In patients with an abnormal pharyngeal reflex, when you insert a tongue blade deep into the back of the patient's throat, you will see no response by the musculature in the retropharyngeal area. Clinical Pearl. Alternative pharyngeal reflex. Another way to investigate the pharyngeal reflex is to perform stimulation of the carina. Some providers feel that patients who have been intubated for a long period of time may have a pharynx that becomes habituated to stimulation because of the continuous presence of the endotracheal tube. Stimulation of the carina can be accomplished by suctioning the endotracheal tube and looking for the patient to cough. In patients with normal pharyngeal reflex, you will observe that the patient coughs in response to stimulation of the carina. In patients with an abnormal pharyngeal reflex, you will observe an absence of coughing in response to such stimulation.
We've demonstrated that there are no discernible brainstem.
When we disconnect the child, we're then going to make sure that the oxygen saturation stays above 85% and that the blood pressure stays above the 5th percentile for age. And in this child, we'll take it to be 75 millimeters of mercury. And we need to observe the child for a period of 5 to 10 minutes. And during that time, we would hope that the carbon dioxide would rise by at least 20 millimeters of mercury.
Please note, if the oxygen saturation falls below 85% or the blood pressure falls below the previously determined lower limit, the test should be discontinued. Before reconnecting the child to the ventilator, a blood gas should be drawn. If the results of the blood gas analysis demonstrate a PaCO2 level greater than 60 millimeters mercury, then the apnea test would be considered positive. Therefore, this apnea test does not need to be repeated, but if this was the first apnea test, you would still proceed with your second clinical exam and second apnea test.
In this instance, let's just assume that we've not seen any breathing for 5 to 10 minutes. At the termination of the test, we would take another blood gas, connect the child up back to the ventilator, and wait for the result of the gas. If that showed a 20 millimeter rise and it was above 60 millimeters of mercury, then we can say that the child has not breathed to that stimulus.
Point of clarification. Please note, the apnea test should be performed following both